อ้าวดังแล้ว ฮัลโหลฮัลโหลภาษาอังกฤษเนี่ย
I, medical cadet Skalandra Skunchai, third year medical cadet, has brought third year medical cadet to the lecture, count a number of 100. At ease.
on your seat. Good afternoon. Today is antibiotic drugs. Just move from pharmacology to parasitology. So now you finish all helminth infection. Can you give me example of the antibiotic drugs? For parasitic tail, for which parasitic infection? When I ask parasitic infection is the name of the disease. Just you have to, opisthocchiasis, not OV. What else? Ivermectin for which parasitic infection? Songiloidiasis. Another? Albendazole. Yes, albendazole. So you all know all of the antibiotic drug, the important one. This is just for the beginning. We can use antibiotic drug for chemotherapy and chemoprophylaxis. Chemoprophylaxis to prevent the infection, but we cannot, from this diagram, we cannot control only using drug. So we need to know the life cycle of the parasitic infection. We need to know reservoir host. We need to know vector. That's not all. We have to give the population education. Something like as in your case discussion, people usually know nothing about helminth infection. So if you give them only drug, you can kill just that. But the behavior never ever change. So they might get reinfection again and again and again. So I'm going to tell you that we cannot use only drug to control the situation in the community. You have to use all of these. We call integrated management, control management. So in one disease, you might need drugs. Sometimes you need vector control, such as vector-borne diseases. Give me some example. Vector-borne. Malaria. What else? Filariasis. Filaria is the worm. Filariasis is the disease. So you need to control the vector of filaria. Okay? And also give the health education. But before you going through this kind of control, you need community participation. You really need this. you have to make them realize that all the disease is their problem and get the community participation. Okay. So this is a strategy of controlling parasitic infection at the community level. Yesterday, you know mass chemotherapy. You know mass chemotherapy. Explain about mass chemotherapy. Can you explain that? Mass chemotherapy or MDA, mass drug administration.
มันคือการที่คนใน population
In English.
อ๋อ when you have a count of the people in the population infected with the parasite more than 40 to 50%.
Really?
Maybe.
And
And you have to give them, everybody just give them the drug to kill each one of them.
everybody.
Yeah.
This is a kind of the control strategy using drugs. If you find the percentage of parasitic infection that high, when we use the method to detect parasitic infection, we usually use something like a stool examination and which one you going to use? If you go to the community base, you want to see parasitic infection, intestinal parasitic infection, you have to do the stool examination. Which one you going to use? Gato smear. However, Gato cannot detect protozoa or something like strongyloides. Not that sensitive. Sometimes you need to use simple smear as well. The problem of this kind of method is that it's not that sensitive. You only detect people who got heavy infection. You miss some light infection. If you can detect 40 to 50%, so many people missed by that method. So it means that, this is what you can detect. However, some people who got light infection will get the false negative result. This is the idea of mass drug administration. Give them all. How about parasitic infection that using this mass drug administration to control the situation? Filariasis, yes, this is the one. Filariasis, you give them just a single dose of DEC to all people in the village. If you find only one, give them all. Some other parasitic infection? OV? No. Any? We give some drug to the population to prevent malaria, to control the consequence of malaria, but not in Thailand because we are low transmission area. But in Africa, we use some drug to control the situation. Mass drug administration in the pregnant women in African country. How about soil transmitted helminthiasis, Ascaris, ticulis, and hookworms? This is some kind of routine control program for the endemic area of soil transmitted helminthiasis. And this figure is used for soil transmitted helminthiasis. In the endemic area, we give a single dose of anthelmintic drug. If primary school children got STH 20 to 50%, we give once a year. But if more than 50%, we give them twice a year. This is all in the program. Even in Thai population, give them something like this. That is mass drug administration or mass chemotherapy. How about OV? Opisthokis viverrini? Yesterday case discussion. Can we use mass chemotherapy? Why? Yes, why? Why yes? Why no?
Because yesterday they have 21.6% infected, and the WHO have the standard in 20%.
So you get the reference from the WHO. The WHO recommend that something like this? Oh. How about no?
No, because there are not enough evidence.
When the WHO recommend that, or when people practice or this kind of control program, you need some evidence. Where does evidence come from? Clinical trial. So, mass drug administration for soil transmitted helminthiasis, hookworm, Ascaris, ticulis, that is saturated. People all agree to use that kind of number. How about in opisthocchiasis? I think we still don't see some kind of that evidence. The WHO say that 20%, but if you look at the evidence in the PubMed, there is no evidence of using praziquantel as mass drug administration. Why? Expensive. Maybe the side effect. Maybe it's related to cholangiocarcinoma, but there is no proof, something like that. So, we are waiting for mass drug administration in OV. This is English session, so it's okay. It's okay. That is one strategies. Another one is selective population chemotherapy. That one is for only infected person. We only use that for very rare, something like neptostomiasis, not that endemic. So not many people got the infection. So we only treat them person by person. We call selective population chemotherapy. The last one is targeted population chemotherapy. We only treat the high risk group in the population, something like this group. Some plastic infection only prevalent in one group. In one group, something like soil-transmitted helminthiasis. Soil-transmitted helminthiasis, only prevalence in primary school children. And these primary school children act as a reservoir as well, transmit the disease to other group of in the population. So if we treat them, we get rid of the reservoir. So we use this kind of strategy as a targeted population chemotherapy. So this is the interaction between anti-parasitic drug, parasite and host. You all know that because you already passed pharmacology 301. For helminth infection, we can divide it into two groups, which are two groups, which are tissue helminth infection and intestinal helminth infection. There's a difference between these two. Intestinal helminth infection is usually mild. If the patient haven't got heavy infection, if the patient got heavy infection of ascariasis, what happened? Loeffler, no. Heavy infection of ascariasis. Intestinal obstruction. How about heavy infection of hookworms? Hookworms. What kind of anemia? Iron deficiency anemia. So you need to know that because it's very typical. Very typical. Because light infection gives you non-specific gastrointestinal symptoms. Abdominal pain, dyspepsia. Do you know dyspepsia? You know dyspepsia? Yes. But for tissue helminth infection, you only get one. You get severe symptoms, something like cystic cirrhosis in your eyes, just one cystic cirrhosis, just one cystic cirrhosis. You get blindness, something like that. So the aim of chemotherapy for tissue helminth infection only treatment, but for intestinal control as well, get rid of the parasite. And the parasite, because intestinal helminth infection, the parasite pass to the environment by feces, isn't it? So you get rid of the parasite in the intestine, equal to control the disease as well. Duration of the chemotherapy is very short for intestinal helminth infection, and also we usually use poor absorb drugs. Compared to the tissue, we need longer duration of the chemotherapy and better absorption. And for the adverse reaction after the treatment, intestinal helminth infection usually, after the treatment, usually cause GI symptoms. But for tissue helminth infection, might cause some severe reaction, especially if the parasite infection in the CNS, because it's a closed system. So we move to the target of the paras and helminthic drugs. So there's two classification. The first one is ion channel and others. For ion channel, if the drug hit this target, it's going to move some proton, and then it causes paralysis. So if you use ion channel targeting drugs, fast or slow action? Very fast. However, if you hit the target, something like a staff, the worms to death, fast or slow? Quite slow compared to ion channel. So you know nematodes, trematodes, and cestodes. You know that? You know that? Mm. Mm. Nematode, trematode, and cestode. Hmm? Mm. There's three classes of helminthes: nematodes, trematode, and cestode. There's only 5 anthelmintic drugs that control all of these parasitic infection, can treat it. Mebendazole, albendazole, praziquantel, DEC, and ivermectin, only 5 anthelmintic drugs. This is the essential one. WHO say that, only 5. The rest is maybe not as good action. Also, it's very difficult to find now. And side effect is really so terrible. Some people say that, oh, they prefer parasite than getting these drugs, thiabendazole. So, we need to know these drugs. Only? Yes. The first one, benzimidazole. Benzimidazole, familiar with the words azo? Azo compound. You know azo compound? What is azo compound? Antifungal, what else? Antifungal, yes. Azo compound, fluconazole, itraconazole, ketoconazole, voriconazole. What else? Another class of azo. Another azo? Omeprazole. Can I record your voice? I'll give it to Ajahn, yes, Ajahn Ken. Any azo? Metronidazole. Metronidazole for what? Antibiotic for another for candida, no, for anaerobic bacteria. This is another azo compound that act on helminth, especially nematodes. This group is just for nematodes, mainly for nematode. The mechanism of action is inhibition of tubulin polymerization, and tubulin polymerization will process for, is the process for what?
Mitosis.
This is the process to build up microtubule, and the microtubule also control the mitosis. Okay. To control the mitosis. Is this process occur in human body? Yes or no? Yes. So it means that it is not that specific to parasite, isn't it? Isn't it? No, because this group of diet is very safe. It means that it's got to be more specific to parasite beta tubulin. More specific to parasite beta tubulin than human beta tubulin. But when you use it for a long time and very high dose, the specificity of the drug is gone. So it could make side effect, terrible side effect. What will happen? So it inhibit mitosis. What will happen? Mhm. Which organ that have the cell division? Lots of cell division. Liver. Cell division. Hmm? Cell division. All the time. All the time. Mucous membrane. Hair follicle. What else? Bone marrow. Bone marrow. Okay. So for the pharmacokinetics, very poor absorption. So most of the drugs stay inside the intestine. It means that this drug is good for intestinal or tissue helminth infection. Intestinal. Okay. So we use it for hookworm infection, enterobiasis, ascariasis, trichuriasis. In the old day, we used the high dose of mebendazole for capillariasis, trichinosis, and echinococcosis. But right now, we only use for these intestinal helminth infection. We only use for this one. Have you heard of mebendazole? Yes. Mebendazole. Do you know Benda? Benda what? Benda 500. Where you heard of Benda 500? AdWords, advertisement in what? After boxing. It usually is Benda 500. It means that one tablet contains mebendazole, 5 milligram of mebendazole. But actually, mebendazole is 100 milligram. Usually use one tablet twice a day for 3 days. For hookworms, ascaris, and trichuris, use one tablet of 100 milligram, single dose for enterobiasis, but repeat it after 2 weeks, another dose. Okay. Why they produce 500 milligram? We usually use 100 milligram. Why they produce 500 milligram mebendazole? Why? We usually use 100 mebendazole twice a day for 3 days. That is a total of 600. There are also 500 milligram tablet of mebendazole as well. Why they produce this kind of mebendazole? Maybe it's got a better compliance, isn't it? 500 milligram tablet, single dose, is maybe got a better compliance. Usually used for mass drug administration. When you go to the community and you're going to apply mass drug administration, whether you apply multiple dose or single dose. Yes, single dose is get a better compliance. Okay. So, adverse effect usually mild, and also maybe present with the GI disturbance very mild. GI upset, nausea, vomiting, and diarrhea. But when you use high doses for a long time, it will increase serum transminase, hepatotoxicity, alopecia, and bone marrow suppression. Why you laugh when I said alopecia? Hmm? This is not alopecia, it's chef. Chef hairstyle. I just chef it. Okay, for contraindication, is known hypersensitivity, first trimester pregnancy, and children age of less than 2 years old. It means that this drug can cause teratogenic. You cannot use it in the first trimester pregnancy. However, when mebendazoles come out, it is very poor absorption, so you have to use it for a long time in capillariasis, in natostomiasis, in trichinosis, because it's poor absorption. So they produce another one, new, another generation is called albendazole. Albendazole is also the commercial one called Centel, and usually 200 milligram per tablet. We usually use 2 tablets, single dose, for intestinal parasitic infection like hookworms, ascariasis, trichuliasis. For the kinetics, it's a better absorption than mebendazole. 15 to 50 times better absorption. So it can use for tissue helminthic infection. After they get into our body, albendazole metabolized to albendazole sulfoxide, which is active metabolite. Then the sulfoxide metabolite further by cytochrome P450 to sulfone, which is inactive one. So this is active one. So for the property of albendazole, it can be used in these parasitic infection, intestinal parasitic infection. The efficacy is as good as mebendazole. Mebendazole 100 milligram twice a day for 3 days. The efficacy is equal to albendazole 200 milligram, 2 tablets, single dose. Which one is better? Albendazole, but albendazole is more expensive. So if you see a patient with hookworms, enterobiasis, ascariasis, trichuliasis, you might use mebendazole because it's cheaper and give the same cure rate. But for parasitic infection, which is have the auto-infection, tissue invasive in their part of life cycle, like capillariasis, trichinosis, strongyloidiasis, natostomiasis, and also larval cystode infection. Mebendazole and albendazole is the main drug for nematode infection. Mebendazole is for intestinal. Albendazole is for both intestinal and tissue nematode infection. But for tissue larval cystode infection, like cysticercosis and hydatid cyst or echinococcosis, we use albendazole. I will say same as mebendazole. The problem is that, this one is meant for tissue helminthic infection. If the tissue helminthic infection die, for example, die in our skull, in a closed system, closed compartment, and it will cause host responses to the dead parasite. It will increase intracranial pressure and cause more severe symptoms. You have to be careful for that. So now you know mebendazole, albendazole, very useful drugs for nematode infection, and also albendazole for larva infection, larva cyst infection. Now we move to, contact is same. Now we move to another important one is praziquantel. From yesterday, you know that praziquantel is the drug of choice for OV, opisthoschisis, OV infection or opisthoschisis. Actually, praziquantel is the drug for trematode and cestode infection, both tissue and intestinal. Roundworm,มีเบนโดโซล flatworm, praziquantel. Easy, very easy. Okay, praziquantel cause calcium influx into integument and muscle. If the calcium influx into integument is cause the bleb, integumental bleb, and expose the antigen to host immune response and then die. Also, when it causes blebbing on the integument of the flatworm absorb the nutrient. So it can cause parasite starvation and die. How about the influx of calcium into the muscle? It can cause a paralysis and then sucker when it causes spastic paralysis. It will cause loss of attachment to the host body. So this is the mechanism of action. Praziquantel is well absorbed in the GI tract and also get into the tissue and pass blood-brain barrier as albendazole. Albendazole can pass blood-brain barrier and also praziquantel can pass blood-brain barrier. So these two drugs can use for neurocystic psychosis. Both albendazole and praziquantel. So for clinical use, trematode and cestode infections, both intestinal and tissue, apart from fasciola hepatica. What is fasciola hepatica? Animal what? Animal liver fluke is resistant to this drug. But usually it can cause liver abscess. Usually we use the surgical removal, something like that, for the treatment of fasciola hepatica. Adverse effect. Actually, this drug is the hypnotic drug. You know hypnotic drug? Drug that can make you go to sleep well, but it also have the action to parasite flatworm, then develop to be antiemetic drug, but it still contain hypnotic side effect. So if they contain hypnotic side effect, when is the best time to give it to the patient? Before went to sleep, not during the driving or something. And it can cause GI disturbance. This is quite severe when the patient got empty stomach. So we usually give the drug after meal and before bedtime, usually that. And also, if the drug kills cystic circuits in the brain, it can cause the same as that happened in albendazole treatment of cystic psychosis. Host immune response and cause increased intracranial pressure and severe symptoms later. And for drug interaction, you can see this. If you give the drug alone, something like that. If you give the drug to dexamethasone, phenytoin, phenobarbital anticonvulsant drugs. It will reduce the plasma level of praziquantel. Consequently, it will decrease the amount of drug that get into the brain. So from this drug interaction, which dexamethasone, phenytoin, and phenobarbital very often we use in neurocystic psychosis. Because neurocystic psychosis come with the symptom of the brain edema, we use dexamethasone to reduce brain edema, and also seizure. We use phenytoin and phenobarbital to control the seizure in neurocystic psychosis. That's why the doctor prefer albendazole than praziquantel for the treatment of neurocystic psychosis. This is the reason why. And praziquantel metabolized by cytochrome P450, so any drugs that affect the action of cytochrome P450 will affect the plasma level as well, like cimetidine. Cimetidine is cytochrome P450 inhibitor. So it can so it can increase the plasma level because it inhibits the cytochrome P450. It might cause more side effect, isn't it? Yes. Oh, yes. Contraindication of praziquantel. Not for pregnancy. Again, no anthelmintic drug for pregnancy. No. And ocular cystic psychosis. Why? Why we don't use praziquantel for ocular cystic psychosis? Inflammation, then inflammation destroy eye, cause blindness. How we treat them, treat the patient with ocular cystic psychosis? Albendazole, the same effect. Surgical removal, just surgical removal. Another one, niclosamide. Niclosamide is an old drug, but you might see this drug when you work outside Bangkok in the near future. You might find niclosamide in the cabinet. This niclosamide is very safe drug, just for intestinal cyst infection. Can you tell intestinal cyst infection? Intestinal cyst infection.